wanted to talk a little bit about the assessment criteria. The assessment criteria from APC, if you have a look at it, it is clearly states what all criteria are there that you have to act out or be able to perform during the assessment. So with APC exam, with the clinical exam, what I found was that it's a bit different than how we usually see a client or how we would approach a client. It can be different with different client, but when you are doing an assessment or the performance during the exam, you have to remember to perform according to the each of the criterias, and that's when you are scored. And that's when you don't miss out. And there are some which are very important and should not be missed out. Most of the candidates I find are miss out on doing the goal setting. Some of them will miss out on doing the consent. Most of them are missing out on the taking the consent as well, and that also affects. And of course, there is the major criteria of safety. And the other criteria to be very careful about or not to miss out is setting the outcome measure, and also remembering to redo the outcome measure to so that you have been effective with your performance or with your treatment. So, it's always good to always, whenever you are preparing for your clinical exam, please keep looking at the assessment criteria. If you're practicing with someone else, ask them to assess you, or to go through the criteria as you perform, and make sure that you are doing for each of it. So when I'm discussing about the subjective and the objective assessment today, I will be putting in points there where 2.1 or 1.A, 1.B, which are saying that which criteria are we satisfying when we are doing this that part of the assessment. Right. So first of all is the subjective assessment. So when we do the subjective assessment, I'll just stop the video here. Okay. So when we do the subjective assessment, of course, as general, you introduce yourself and the examiner, and it's at the beginning itself, it's very important to take consent, because that's the part of the first section 1.A, where it states that you have to obtain consent. So please remember that, because if you don't do that, then you get a 0 on, or a cross on the 1.A1 criteria, and then you miss out on one part. And as you keep missing out on each point, it adds up. And if there are too many points that you have missed out, then it's a fail. But if you miss out a few points, I have seen that with various feedback that the various feedback of the examinations that the candidates get, if you fail even in 2 or 3 criteria, they still give you an overall yes. So it's all right, but it's important not to miss the important ones, as I stated earlier. Then remember to do the identification, name, date of birth, time, and orientation to time, place, person. Asking how, I'll start by asking how are you today, and what are your current issues. And then when you start with that, you're starting to build a rapport. And that is also one criteria. You have to always work on building a rapport with the client, or with your, model there. The client or the patient could be, acting out, trying not to be comfortable with you. Even for my exam, I had got a client who was had a cardiac surgery, and then he was very scared and was crying constantly, and he was he needed a lot of consoling, lot of advice and encouragement to get him standing and walking. But because I was, because you are able to convince that person to stand up and walk and bring him out of the room, you have got an outcome already. So they may create scenarios like that for you. Right. And right away, what I say is what's best is if you see that the person is very acute and already in oxygen level, then immediately please check the oxygen level, because few exams they have set in the file, it will be written that it's 2 liter per minute or anything. But then in the in the setup they may not do that, or they may fail you saying that you didn't check the oxygen level, because that has happened as well. Also ask them for their comfort, bring the head up slightly so that you are at eye level with the client, but always ask them if they are comfortable to do that, so that you are with that you are doing the safety check. So you are doing you are fulfilling the criteria of 1B3, which says that you would be safely assessing the client. Then the second thing is like ask for pain right away. Always at the beginning, please ask for pain, because if they have pain, you have to ask them, have you taken your pain meds, right? And then if they haven't, then you have to like say, can I ask the nurse to get pain medications for him? So then this will prompt the examiner to say, that's all good. The nurse has come and given the medications. And then also that means that you will have like 10 to 15 minutes before the pain medication starts working, so that the client will then cooperate with you when you reach the objective part, or when you need to move the patient. Otherwise they will, if you're too late in giving pain medications, the actors know that they have to act out saying, that's too much pain, I won't do it. So that's how some scenarios have occurred. Also, when giving pain medications, it's good to give them education about why pain medications is so important. And that then gives you, if you do that at that point, you then are able to get the 4.5 criteria, which is saying like giving them on education and strategies for self-management. So if you are empowering someone with our understanding of medications and why pain management is important, you are given that, fulfill that criteria. So there are these small points in every part as we go, where you can score the criteria or fulfill the criteria. Right. Then next we have the in the subjective assessment itself, like confirming from your file all the current history, CLFU. So before you see the client or the patient, sorry, you would have like some time for yourself to look at the file. When you look at the file, check for the current history, current level of function, current medications, course of disease, and all of these, also past medical history. So look for all of that and confirm briefly with the client. Don't go in detail. So just confirming it. So that means you are fulfilling another criteria as well. That is compare the finding with what is expected for the condition and excluding the altered diagnosis. So in cardiorespiratory, you don't really need to diagnose the condition, because it's all given in the file, so it's very easy. The only thing is that you have to look for the right symptoms. Like if someone has asthma and then you don't ask about breathlessness, then you lose that criteria. You get a cross on that criteria. So always, that's why it's also good to prepare yourself for each of the condition and what symptoms to confirm or what symptoms to look for in the client or the patient. And then look for the current level of function, ask for the bed mobility and transfers. Of course, this all will be written in the file as well. Confirm from there, but also ask the patient, please, because sometimes it has happened that it's something different is written on the file, and then when you ask the patient, they will tell you something different. So it's very important to confirm everything with the patient, and that's how we do, even if we are out there in the hospitals in real life as well. Then also when you ask about transfers or walking distance, ask them about if anything stops them from doing anything further, like if you can't do walk out of the room, then what's stopping you from walking out of the room? Is it breathlessness? Is it pain? Is it you're getting too tired, or is it that you don't want to do it at all? And at that point, if they say breathlessness, then right away please remember to ask about puffers or GTN spray if it is a cardiac condition, because then you have to remember, when you ask the walking, if they say yes to these medications, means you have to then ask, where is your puffer, where is your GTN spray? And usually it will be in their bedside table or somewhere, or if there's not, then the examiner will say that, yep, there is a puffer. And then you have to then say that, okay, I will keep that with me while I'm doing the assessment and during the treatments, just in case you need to use it. So that again, you are doing the assessment and the treatment safely, so you get a tick on that right away. then of course confirming the previous level of function as same as above, like how you were before. So when you ask about previous level of function, you are already starting at working towards your long-term goal, because you will know how the person was before when he got admitted or when he got worse with his condition. So you're already working towards your long-term goal. So very important to ask the previous level of function as well. Right, then we have the shortness. Then now after this, we start looking into each of the 5 cardinal signs. In cardiorespy, there are mainly 5 signs. The first one is shortness of breath or wheezing. So you ask for, when you ask for walking or any activities, he would have told you already. But when you ask about the shortness of breath, you are fulfilling the 2.2 criteria, that is like comparing the finding of with what is expected for the condition. So you are conforming with that, and also then doing the IB.2 criteria, that is like examination and finding the right signs and symptoms in the person. So then ask what do they have a shortness of breath? If yes, then use the Berg scale. Berg scale is there in the storeroom. So you can, if you have a cardiorespy, I would just grab it right away, because most of the cardiorespy cases are having some breathlessness. So when you are going in when you get your file, or when you know it's your cardiorespy, you can go and say, I'm going to take out or get some one Berg scale from the storeroom right away. You can do that as well, or you can so that you can use it with the client and then ask them if they have any wheezing. Wheezing is that musical sound or that high-pitched sound that a person makes when he's breathless. Then you can also ask, if they say yes, then explore further on, is it on rest or just with exertion. The one thing to remember here is that when you are asking about shortness of breath, look at them, how they are presenting as well. Some will talk to you and then not be able to finish a sentence while talking. So that means they are already breathless. Like if they are gasping for air in between, they are already breathless. So that means they are already short of breath at rest. So then you already know the answer. You can just say, oh, I noticed that you are still getting slightly breathless. So that means you are, already indicating to the examiners that you have good observation, and you have again conducted your observation as well along with the subjective. You could ask them what provokes their breathlessness, to what extent does it limit their functional abilities, like how far are they able to walk, what all can they shower by themselves, or they're too tired to shower by themselves, some questions around that. And then what helps to bring the breathlessness down? Is it the puffer? Is it that they need to sit down? Do they like lean forward? Do they do anything that helps them? Some might say it's like I have to lay flat. Some will say I can't lay flat at all. So instead I have to lean forward. So that's what you look for here. And then, as I said, positional, they could tell you like I can't lay flat at all. So that means that they have they have increased breathlessness when they lie flat because of the increased cardiac afterload, and that could be the reason. So they or could be the diaphragm is pushing up when they're lying flat, so they get more breathless there. Then this I have all just explained earlier, the Berg scale that you can use, the modified Berg scale, and this is there in the lab as well. So you don't need to memorize this. You can just go and pick one of the scales there. The other thing, as I explained earlier, like using the breaths per sentence as well is a good technique to note how breathless they are. Because sometimes some of the scenarios, the patient is like not accepting he's breathless. He will say, no, I'm fine. Like there is a patient, older patient scenario where he keeps refusing about his breathlessness, but he will take lots of gasp in between, and that can be used, like how many times he's like stopping to take a breath, or how much is he showing his anxiety, or how much is he needing to stop when doing any activity. So that, or you can also look at the accessory muscle uses, that is the muscles around the neck here, like look around whether there's hypertrophy of the sternocleidomastoid or around the neck, and then also look for any signs of active expiration. This is a bit tricky to see because then you have to look at the tummy or and like raise the cloth and look at it. So you can ask permission to do, always ask permission if you want to do that. So here I mentioned a point about cognitively impaired. That's because like that scenario where there is a patient who is not accepting or not realizing that he is breathless, and then he so many candidates there have failed to recognize that and failed just because they didn't acknowledge that he's breathless, or didn't educate him about his breathlessness, didn't make him aware. So that's also very important. The tricky bit is that now, because they are wearing mask, it's quite difficult to look at breathlessness, but because otherwise, you could see their nasals flaring and you could see their pursed lip, but you can always like listen if you can clearly listen them breathing hard. I mean, that is my experience. Even with my patient here, they are always wearing masks, but I can look at them. I can look at their shoulders starting to shrug. I can hear the heavy breathing, and based on that, I can say that now they're getting breathless. All right. Then the next thing to look for is cough. Do you have any cough? Is it and asking them, is it normal for them? Like, because some conditions have chronic cough, they will have cough once a day or like few times a day, every day, and which is normal for them. So just ask them, like, is this normal for you? Do you normally have this amount of cough every day, or is it more than before? So that's really good to ask that. Then the examiners already know that you understand that this condition is chronic, and in chronic condition the symptoms may be there throughout, but what you are looking at in this client is the exacerbation of symptoms or the increased symptoms. And then looking for cough, you look for moist versus dry sounding cough. Is it gurgly or is it dry? So I don't know how well this would be acted out, but you could just ask, like, is this like, am I hearing? You can ask then, am I hearing a moist cough or am I hearing a dry cough? And usually the examiner will give you the prompt. And again, productive versus non-productive. Are you bringing up any sputum with when you cough out, or nothing comes up at all? And effective versus ineffective, just ask them, like, are you able to bring out the sputum and reduce your irritations when you have a cough, or is it just that you keep coughing and you're not able to bring out anything? So that tells you the thing. Then you'd ask about how many times a day you are coughing, how frequently you are coughing, and then is it painful? Does it hurt around the lateral chest, or around the tummy, or even like throat? Some will have pain around the throat or the central chest area. And is it inhibited? Like, inhibited means, because of the pain, they are not coughing as hard as they want to, and they're avoiding that. Are they doing that? So it's good to ask all of this, because then this when you ask these things, these are already giving you goals to work on. If you know it's painful, you already know, now I have to splint. Give them splinting. If it's inhibited, then again, okay, it's too painful, give splinting, give pain medications, teach them good coughing technique because they're not doing it correctly, or maybe a huff technique. So you already get your goal as you go through this. Yeah, and next, the sputum. You are then looking at do they normally produce any sputum, or is it like the color and quantity? When they say they do, then ask them what's the color, is it white or yellow, and how, if there is any smell. So usually it's enough to just ask, like, what's the color of the sputum and what's the quantity. Is it 1 to 2 teaspoon? Anything more than that means it's an increased amount, and the color, as it's yellow or creamy, it becomes infected or state, or even green is the most infected state. And then also to ask consistency, is it like very thick and tenacious and is difficult to bring out? So then if they say yes here, then you already have a goal here saying, it's difficult to bring out, you have to do some airway clearance technique for this client. Then you have got the question about hemoptysis, is there any blood in your sputum? This is again good to ask, because then you are making sure there's safety of the client. You are, because that's one of the symptoms to look for, to be careful about. So you are doing that as well. The next sign is chest pain. Asking about again the pain as same as how it would be with any other pain symptoms, like what side severity is in the VAS scale. Now here to ask is like, is the pain causing you to not being able to breathe deeply, or are you able to cough or not because of the pain? And what stops you, what you can't do because of the pain? Is there anything you are not able to do anymore because of the pain? And what relieves the pain? So ask all of that. And yeah, again, the same question as I said earlier, if they have been coughing at all, if usually with chest pain, they will say that they cannot cough and it's usually inhibited. So you already get a goal around that right away. If it is a cardiac condition and there is a history of angina in the files, then do ask them about when did it happen, and what are the, like, you can like just confirm like what from the file about when did it happen, how did it happen, was it exertional or just at rest, what was the aggravating factor, what helped him to just bring him down, and always ask whether he has the GTN spray or not. You can also confirm about GTN spray from the file itself, because there will be a medication list at the beginning of the file, and ask him about the symptoms that he gets when he has angina, apart from chest pain, and clammy, sweaty hands, cold sweat around the forehead or the neck, and fainting or dizziness. So ask him about this, and at the same time educate him that you might get these symptoms. So if you do get these symptoms anytime today, you have to stop and let me know right away. So you are educating, is fulfilling that criteria as you go. So you're really ticking a lot of things as you go. Then some of the red flags to go through, and I use this I use this mnemonics of BB, PP, WWFF. BB, asking about bowel and bladder, if there are any issues with that. Nothing usually comes up. Nothing usually comes up, but it could be that sometimes they may have urge incontinence when they cough, or stress incontinence when they cough. They lose a little bit of, or they leak a little bit of urine that they may say. Then pins and needles, especially if it is a post-op client, then you have to ask if there's in pins and needles, if there is any excruciating pain at night that doesn't let them sleep, any weight loss or weakness, especially important to ask for limb weakness after post-op, because if someone is like not even stood after post-op, then do have to ask them like, how do they feel? Do they feel they can't move their legs at all? Then how tired do they feel, and have they had any fevers and chills in the last 1 month or so? So these are our red flags for the cardiorespiratory cases that are the common ones to deal with. So after about 9 minutes, on this one will I will log out of this link and we'll go to the part 2 link. I hope that's all right. Let's go on to the next one, that is looking at previous history. In previous history, you would look at the previous history from the file itself. There is always a summary there which lets you know about all the previous history. And then, but just when you go and talk to the person about the previous history, just list them out saying, okay, do you have diabetes? I have seen from the file you have diabetes, this. Is that right? Right. So if you have, you have COPD as well, right? How are you normally managing? Do you have do you have your medications? Do you usually take your medications? And then ask them if they have an action plan being given by the GP for the management of exacerbation, especially for asthma. They will all have this action plan. And if they say they don't, then you can say, right, I will now refer to the doctor or to your GP about this. And that again gives you another tick there, because you are helping with self-management. You are helping with the identifying the right referral for a referral pathway for this patient, and then confirm about previous hospitalization, whether they have had any pulmonary rehabilitation or cardiac rehabilitation before. Very important to ask this if someone is a chronic one, like chronic COPD, chronic asthma, someone with lots of CABZs in the past, or had lots of MI, 2 episodes of MI in the past, means they would have gone into some sort of rehabilitation. So very good to ask this. That then makes your job easier. They would have learned many things before. The actor will present with saying, yes, I know about huffing, I have learned this before. They will usually present with such things, so it's easier for you as well. And at the same time, you are also identifying, like looking at areas outside your skill, because within the exam itself, you can't really deliver pulmonary rehab or cardiac rehab. You can only further refer them to this service. So you are already talking about it. So you're getting a tick on the 2.5 as well. Then please do remember to ask for specific conditions like diabetes, hypertension, cancers, any surgeries and heart conditions, like just because these are some of the major ones to remember, as with in cardiorespiratory conditions. Right, and then I have this another mnemonics to remember, SOEP, and this is to remember just around the person itself, the social history, how is the occupational history, environment history, and his personal history. Social history, it's important to ask, because then you know whether you need to refer to a social worker, or maybe a CAT assessment, or maybe refer to home care services. So it's important to ask, like, okay, who are there in your home, who can support you once you go back home if that person is in hospital. If the person is coming to you in a rehab setup, then like who's at home to help you to do your ADLs, because it seems you need help. So if they say no, then you need to refer to the social worker. ACAT is a aged care assessment team, and they can assess someone to provide home care packages, but this is for someone above 65 only. Below 65 would be the NDIS assessment. Then again, home care falls under the ACAT as well. Occupational history, very important to ask to form long-term goals. Like, what were you doing before? What work were you doing? Are you retired or working? What are your hobbies? And immediately when you ask these questions, they tell you so much about their personal self. There is a rapport building as well, and right away you can form a goal. You plan a goal, long-term goal there. In the environment, it's a double story or single story is important to ask, because if that client is breathless and doesn't have or hasn't really done a stairs here yet in the hospital, then you can't send him home without doing the stairs, or without letting him understand that he has to be in the ground floor for some time. So that's why important to ask that. And then ask about environment, like fall risk in this environment. That would be maybe asking, is there, if the client is a frequent faller, you would be asking that, and then asking at home, like, is there like carpets there, or is there, areas to grab rails are there or not? Then here when you identify any environmental issues, just say that, okay, I'm now going to refer you to occupational therapist. So you are again ticking off a criteria of referral. Then asking about smoking and drinking, so that you can refer to the dietitian if they have, or a smoking cessation program. Quitline is the one that you can refer to, saying like, I will now, if and of course, please do ask for their permission or their willingness to give up smoking if they are smoking, or even if they are drinking, then tell them and ask them, tell them that it's important to give up drinking and smoking, but then it's their choice. You can't right away say, all right, I'm now going to refer you. Ask their permission to refer to the dietitian or smoking cessation. Right, now we come to the end of the subjective one. And then from this, we are already able to, as we go, we have already been able to look at goals. So any questions so far? Otherwise, I will just start with the goals in the next one, so that if there are any questions, please.
Yes, I found that you said fatigue is a red flag in the cardiac patients.
Mm-hmm.
I think most of them after cabbage, they get low exercise tolerance, and fatigue is one of the symptoms.
Yes. Yes. Yes, so the fatigue would be, I'm not saying it's yes, it's a red flag in the sense that if someone is extremely tired and extremely like malnourished as well, and it could be related to his medications, could be related to his nutrition level not being right. So that's when like it becomes a red flag. Of course, after surgery as well, if someone is extremely tired and like saying, I can't do anything for you, I will not do anything for you today, and just go away. So that's a red flag. Then what you can do, because of course you have to make him do something, otherwise you are not passing. So you have to then look at saying to the examiner, can I talk to the nurse? Maybe there is some medications that he needs, or can I will report this to the surgeon. However, I kept that fatigue as a red flag because it's something to keep in mind that the person is really tired already, so that you can monitor the symptoms more closely, sort of.
Yeah. So we normally ask for fatigue in cardiac or pulmonary patients. And I'm asking you now, we can use the visual analog scale to rate their fatigue?
No, don't use the visual. I would use the Berg scale. I mean, there is nothing wrong with using visual analog.
Oh, I mean the Berg scale, whatever. I mean, like,
yes.
How much out of 10? I mean,
yes. Perfect. Yes, I would use the Berg scale, and that's your outcome measure already. Because then, if you let's say he says 7, and then next time he then says he's better, and then he does some activity and he says, oh, I feel better because I have like taken a break in between and I don't feel that tired anymore. So you're already getting some better score. So yes, I would use Berg scale. And who to refer to for alcoholics? I would refer to the dietitian or the GP. There is a Alcoholics Anonymous Society, associations as well, but like GP is best to, or the dietitian. I would do that. In the bowel, I would just ask, like, are you, for the red flag part, I would just ask, like, are there any issues with your bowel movement? I've just used that, I've never explained it more than that, and they immediately have